That's a very important issue because, for example, when a woman develops high blood pressure during pregnancy, everyone thinks it's expected, but that's actually abnormal. And any type of high blood pressure, whether it's high blood pressure or preeclampsia or toxemia, that confers a risk for hypertension later in life and for cardiovascular disease later in life. And it's very important to alert a woman because, yes, a woman typically goes off and starts raising her family and takes everybody else to the doctor, and all she needs to do is get her blood pressure checked twice a year. And to be able to follow that and to be able to get that before she has kidney damage, a stroke, or cardiovascular disease from hypertension. Well, I'm fortunate because I see them when they're pregnant. So everybody's very involved about their health when they're pregnant. So we do make sure we get all those messages out. For women, let's say, who have polycystic ovary syndrome, who had trouble getting pregnant, and there were fertility issues. Well, later in life, they develop some metabolic issues that are direct risk factors for cardiovascular disease. So we try to get that message out then, too. Public service. Not only do we educate health professionals, but we also educate the public when we do our symposia to try and get these messages out. And so that mothers worry about their daughters and daughters worry about their mothers and their aunts and everybody else. But because I think it's just it's an education, because there's still women out there who think that cardiovascular disease, it's a man's disease and I don't have to worry about it. During pregnancy, it becomes challenging to treat patients, but not impossible. And it's very important to do a preconception evaluation when a woman is on a medication. For example, a woman who has a defibrillator. She needs to be on a beta blocker to keep that defibrillator from firing, or another antiarrhythmic drug. That needs to continue during pregnancy because that's the last time you want her defibrillator to start firing. So you want to maintain those drugs. Some beta blockers are better to use during pregnancy and not, but all of those things are really important to establish in a preconception evaluation so that we can get things set out ahead of time, predict risk, make sure sometimes, for example, another population, the congenital heart patients, they leave the children's hospital and never look back. Then they decide they want to have a family. Well, it's a great time to come in because they may need a new valve, they may need some sort of correction that would make them a better candidate for pregnancy and have a better outcome. So you can use medications safely during pregnancy. We try not to use them in the first trimester, but we don't want to stop a woman's medications abruptly. And if she needs it, then we have to make a very important decision about the risks and the benefits. Certain medications we know we should not use during pregnancy, although those rules are starting to expand a little bit now too. Women who are obese, have pre-existing hypertension or polycystic ovary syndrome certainly have increased risks of diabetes during pregnancy, hypertension during pregnancy, but that's a whole other group. I'm talking about women who were born with heart disease, who were blue babies and had surgery as a child, and now they're doing everything everybody else is doing, but pregnancy is a challenge, and we need to manage that challenge. Some women who, let's say, who were not repaired or developed high pressures in the lung, they should not get pregnant. And so that we may have to manage that as well. But that doesn't mean that they can't have other procedures like an egg harvest and in vitro fertilization in a surrogate. So we really try to facilitate that in a rational manner.
So you do all the pre-pregnancy stuff, you get them through pregnancy stuff, and then, hey, they have a kid. Now what?
Well, there's a risk that the child may have congenital heart disease. That's a whole other story. And then you know, they think that in retrospect it seems so easy to go through that pregnancy. So then when they want to do another pregnancy, then we do an evaluation again to make sure it's still safe for that. And then because the most important thing is to have somebody in good condition at the end of the pregnancy. Because as I tell my patients, that the hardest part of having a child is really the next 18 years. And I would like them in good shape to be able to enjoy their children. Having a child is one thing, but enjoying your children is the key thing. We've established this care when they get referred to me during pregnancy and they have congenital heart disease, then I will continue to follow them in my congenital heart clinic. Or sometimes I will follow other people's patients and then they'll be already established for cardiac care. So we work together. We have a lot of patients coming from all over the tri-state area, really, for preconception evaluation. Now, when I first started doing this, I learned everything by taking care of women who sort of showed up at 24 weeks pregnant with all these unusual illnesses. But we learned that we could do much better if we could see them before the pregnancy and plan things out in a very rational manner. Most OBGYN doctors want a specialist to help them through this. And because you have to have somebody who can understand the hemodynamic changes of pregnancy, which medications you can use, which medications you want to avoid. It makes their life a lot easier. Otherwise, they would abdicate their care to like a high-risk OB. Now, I work with a lot of high-risk OB physicians, but they also have, a limited cardiac involvement, and it's really to have that vocabulary and to be able to do that. Now, one of the most interesting things that we do several times a year, we get together. I get together with the OBs, the high-risk OBs, the fellows, the residents, the OB anesthesiologists, the nursing staff, and we come up with a plan for our complex patients. And that plan is in the chart. So no matter when they come in to deliver, everybody's literally on the same page.